course. Okay. Well, whenever you are ready.
Okay, perfect. So the situation is that I'm presenting on a client I am working with in my clinical placement for the next clinician that takes over next semester. It is a third grade male student with a diagnosis of autism spectrum disorder. He presents with significant expressive and receptive language delays, which impact his ability to answer age-appropriate questions, effectively communicate with multi-word utterances, and self-advocate. The background is that the student is currently placed in a self-contained SOAR classroom due to his diagnosis of ASD, as well as his various behavioral and academic support needs. The student currently receives direct speech and language services through his IEP 2 times a week for 15 minutes, with goals targeting both receptive and expressive language. The receptive language goal specifically targets understanding and responding to egocentric questions, and the expressive language goal focuses on expanding his utterances to 4 or more words. The student responds well to verbal cues, specifically reminders of strategy, and has been making steady progress towards his current goals. However, he continues to demonstrate significant difficulty understanding questions, specifically egocentric ones, consistently using multi-word utterances, and learning new vocabulary. The assessment is that the student's expressive language skills are below age expectations in both length and complexity. He also demonstrates inconsistent use of verb tense, plurals, possessives, and sentence structure. He also currently has a limited vocabulary and often relies on gestures or unintelligible vocalizations to supplement this. His receptive language delay also further impacts his ability to understand and respond appropriately to questions, especially egocentric ones. And he exhibits challenges in social or pragmatic communication, specifically with self-advocacy due to these receptive delays. The recommendation is to continue the direct speech and language therapy 2 times a week for 15 minutes, focusing on expanding his receptive and expressive language skills. It's recommended that these sessions incorporate both visual and verbal cues to support the client's comprehension and expression. And it's recommended that the therapy target sentence formulation, grammar, vocabulary development, and strategies for answering and responding to egocentric questions. Do you have any questions for me? That's all I got.
I think that was really good.
Thank you. Yeah, the only thing is so I'm in one of the schools for the placements right now. So we don't have like a whole lot of information about like his previous or how long he's even been in speech. So that's stuff I gotta figure out. But this is what I got from like the IEP I got to look at for one of the days.
Yeah. No, it's tough because we're, I think, all in the same spot of like, we've been with them for a little bit, but not long enough to know all of the details, but I think we have enough. But what school are you at?
I'm at Field Elementary.
Okay.
Yeah, right now in Mesa.
Cool. Well, I don't have any questions if anyone else does.
I don't.
I don't as well.
Okay.
I think that's a good sign.
There's a thing where a Google Doc we're supposed to fill out like as each person does it, I guess.
Yeah, or after, last year when we did this, the second, like everyone just kind of, after the person was done presenting, we just took like a minute or two to fill it out and then moved on to the next person.
Okay.
Yeah, so that way you don't have to, I guess, worry about like listening and trying to fill it out all at the same time. But
Okay. It just said, I have the following advice. I don't know what advice. I don't know what to give because I don't know what I'm doing. So
that's fair. I guess, I don't know. I guess if you don't have anything, I feel like on some of mine last year, I was like, nothing is good.
okay.
But
I would maybe say, just like slow down your rate of speech just a little bit.
Yeah, I am a very fast talker, so that's
Yeah, and that's nervous too, like, but when you're presenting for like the professors or whoever, just like really slow down because they'll make a comment about that.
Gotcha.
so just fill that out and then we can go to you, Jen, whenever you're ready.
Okay, I'm still trying to get this open.
Oh, so we should fill it out now then?
Yeah, so yeah, we'll go ahead and fill it out for
Well,
you.
I think that I don't know if you guys fill out one for.
I was gonna say,
they
I
only.
don't know if we just do them for the PICOs and you guys do them for SBARs, I think. right? I don't.
It says on the Excel sheet, says Google Form rubric for first year SBAR presentations, Google Form rubric for second year clinical based PICO. So,
Yeah, so that's the one you guys will fill out. But I thought I remember doing one for everyone, but maybe not.
yeah, like it doesn't say not to. It just says take a minute to fill this out
Yeah.
after each presentation. So maybe we do it for everybody.
I think you do. I think everyone fills out each form.
Just not for ourselves.
Correct, yeah.
I'll give myself a really good score.
Fives across.
Will you say one more time, Gianna, like what was the type of questions that you were wanting to?
Oh, it's egocentric questions.
Okay, I couldn't remember.
Yeah, questions about himself.
Okay, I'm done. Are you guys still working?
I just need like 30 more seconds. Sorry.
Okay.
Same. All right, I'm good whenever you are, Sam.
I'm ready.
Okay. Jen, what's your last name?
Weaver, Weaver.
Okay. I just want to make sure I'm clicking on the right one.
Yes, that's a good idea. Yeah, there's another Jen.
All right.
Okay. So this is like I'm giving to my supervising SLP. I'm also working in a school. So that's who I'm like I'm talking to. Who I'm pretending I'm talking to. Okay, so the situation. Also this is a student that only I see. So it's like I'm giving the info to my supervisor for progress report and upcoming IEP. Okay. I wanted to give you an update as we discuss the upcoming progress report and IEP reevaluation, which is due in November. I want to talk about creating a goal for improved AAC use since this student is currently using her device minimally on her own. She has significant reading, writing, math, and communication delays. She also needs a lot of prompting and support to stay focused and complete her work. And the background is the student is a 10-year-old female fourth grader with mild intellectual disability She has a medical history of repeated ear infections and has had PE tubes placed twice, along with a tonsillectomy and adenoidectomy. She's a real social butterfly. She loves interacting with people, and she has a strong desire to communicate with staff and students. When we walk down the hall, she's eager to say hi or hug everyone that she knows. She's shown some growth in phonemic awareness and number recognition and really enjoys technology-based activities. She uses an iPad with touch chat for AAC, but she still needs frequent modeling and prompting. Frequent modeling and prompting to use it effectively in class and during daily routines. She currently receives speech therapy, occupational therapy, and adapted PE. Her main challenges continue to be communication, attention, and independence with academic and daily living skills. My assessment is that she's making steady progress toward her IEP goals, especially in phonemic awareness and number recognition, but she still needs consistent visual support and one-on-one prompting. She has trouble following multi-step directions on her own and struggles to carry over skills that she's learned without any help. Her limited use of AAC device is still a big barrier to communication and participation in all different settings. For recommendations, I recommend that we continue her current services in speech, OT, and adapted PE. I also think that we should add a new IEP goal that focuses specifically on improving her independent and functional AAC use. I want to work with you, like my supervisor, to get more information about how she's using her device at home and in the classroom so that we can make sure there's consistency across environments. We could keep supporting her through frequent modeling, aided language input, and guided practice with her device. I will continue using visual supports, structured instruction, and consistent routines to help build her independence while monitoring progress toward her other academic and communication goals. Do you have any questions for me?
I thought that was good. Did you include in the background or in any part, I might have missed it, what type of classroom she's in at the school?
Oh, that's a good point. I don't think I did. It's called MI because I work for Mesa School District, so it's a mild intellectual disability room.
Okay.
So that would be probably added to the background.
Yeah. Are you in the PET program?
Yeah.
Okay. Are you doing that, Gianna?
No, my clinical placement is just
Okay.
public schools.
Okay. Yeah, and I think that too for you, Gianna, if you haven't included that in your background, what type of classroom your student is in,
Gotcha.
maybe. But it sounds like your student would probably be more so in gen ed. But yeah, I would just include that. I think that's always a good piece of info.
Yeah, I'll say let's see, because I said she has a mild intellectual disability. I'll say something like fourth grade. She's a 10-year-old fourth grader in a self-contained. If I said MI, I mean my supervisor would know what that means, but
I think just if you're presenting to someone who doesn't know her full thing,
yeah.
that
I
would
just
be
was
good.
trying to figure out where to add it, that it didn't sound repetitive with because I said the fourth grader with mild intellectual disability. I'll add it somewhere because that's important.
I think just self-contained is good.
Okay.
I think that leaving it at that, because every school is very specific about the types of classrooms they have, and you could go off on a whole thing about all the school I'm at right now has 4 different special education layers, and so self-contained I think would work. But I thought that was good.
Okay.
Yeah, I have no questions for you regarding that. Just my one thing, I mean, this is I don't know, but when I don't know who you'll have to present to, but last year I read directly from the script and then they mentioned that. So just
Yeah, that's true.
work on
I presented it last week to Kelly and I had to redo a good amount, so I guess I'm I was like not as familiar with what I rewrote because I didn't
Yeah.
practice.
No, that makes total sense. Just a little tidbit.
It's a good tip.
Other than that, I thought it was good. Rate of speech was good. I mean, it's also me because I just like can't pick up information quickly. So I like when people talk like really slow. But I also like the pertinent health history that you put with her regarding like the like adenoids. That's definitely wrong.
Yeah, I didn't. It's kind of like Gianna, like I couldn't get a ton of background on her, and that was like the only thing in her IEP that I was like, oh, well, maybe that's important. But I wasn't really doing like recommending like another hearing test or anything, but I still just put it in there because it was like the only bit of health history I could find.
I'm ready when you guys are.
Me too.
Like 2 more seconds. Right. Sam, do you want me to go or do you want to go?
I can go. I have mine pulled up.
Okay, I don't have mine, so that works out.
Okay. Just so you guys know, this is a very, very rough draft. So please take that into consideration. Oh, wait, wait, I'm sending a request to share my screen. Oh, thanks. Okay. Can you give me like a thumbs up if you can hear it? Okay, 2 seconds. Wait, hold on. Can you hear that? Because I can't hear myself. Oh,
Your delay.
oh, okay, hold
So
on.
for the agenda for today's presentation, I'm going
Wait,
to be
sorry.
talking about the
You know,
situation or
can you
who
hear it
is the
okay?
client.
Yes.
We'll be discussing the
Okay.
background or my PICO question.
Oh, sorry.
I'm going to be talking about the situation or who is the client. We'll be discussing the background or my PICO question. We'll be discussing the assessment, the evidence that guided my intervention, and what we did in the classroom and at home. And then to complete it, we'll be talking about the recommendations or my clinical impressions. So just to begin, I'd like to go over some vocabulary or key terms that you'll be hearing me say throughout this presentation. This will make sure that we'll all be on the same page throughout the case. So the first is AAC. This is augmentative and alternative communication. Joint attention is the shared focus of an object or activity with another person. Push-in therapy is intervention delivered directly in the classroom alongside peers and friends instead of pulling the child out of their environment. Pull-out therapy, on the other hand, is removing the child from the classroom for therapy in a separate room, usually individually or with a small group. Child-led play is the child directs the activity and the clinician or therapist models language and interactions based on their interests. They can model and expand on the language. Dialogic reading is interactive reading where the child participates and adds on language. And then parent coaching is training parents to support language development in their natural routines at home. So the situation, Jackson is a 4-year, 7-month-old preschooler who is currently non-speaking. His father is hesitant around labels or a formal diagnosis. So we want to approach the intervention with neuroaffirming practices, which focuses on strengths and engagements rather than deficits when it comes to Jackson. So Jackson's main goals were to use AAC to comment, request, and express knowledge. We wanted him to engage in joint attention and then following a 2-step classroom direction. So I chose this case because it's a great example of how to implement evidence-based practice while respecting family preferences and promoting generalization of skills. So Jackson is currently enrolled in an integrated preschool program, which allows him to interact with peers who are typically developing. He has made progress in following 1-step directions and engaging socially, but he's still mostly nonverbal. So we have been providing parent coaching to help his father support language development at home without formally labeling him. And this is a family-centered approach which aligns with the neuroaffirming principles. So for the PICO question that we're responding to in this case is, in a 4-year-old non-speaking preschooler, does push-in therapy in the classroom compared to pull-out therapy improve language generalization, peer interactions, and the ability to follow classroom directions? So I broke that PICO question down into population, intervention, comparison, and outcome. And you can go ahead and read that there. The comparison would be pull-out therapy. The intervention is push-in therapy using child-led play and dialogic reading, along with parent coaching, what we're currently doing. So this PICO question is going to help me focus on my clinical decisions. So what we are doing right now for our evidence-based practices is we are doing push-in therapy. Research supports that push-in therapy for promoting generalization of language skills is beneficial. And then studies indicate that embedded interventions help children practice skills in real-life context with other peers and teachers, which then leads to better functional communication as compared to pull-out therapy. Child-led and dialogic reading also have strong evidence backing them. For example, child-led play promotes expressive language and joint attention, while dialogic reading increases vocabulary and comprehension. Finally, parent coaching helps reinforce these strategies at home and supports AAC use and communication independence. So the intervention that we are doing is push-in therapy, child-led play with modeling, dialogic reading, and parent coaching at home. So the assessment progress has been shown with Jackson using single word, beginning to imitate phrases. He's also responding to story questions when given choices. He's adding language to his play. He is jointly playing with peers and following two-step directions with minimal prompts. He's also increased his use for AAC with commenting, requesting, and expressing knowledge. So these are all made with our push-in therapy during classroom routines. So we're integrating his AAC use during the classroom. We're integrating dialogic reading in the classroom, which helps with vocabulary and comprehension. And then finally, the parent coaching side to it helps with the home environment. So some barriers that we are facing, sometimes Jackson can become frustrated when asked to communicate independently. And so to address this, we're providing lots of support, visual supports. We're offering choice-making opportunities for him to decide between two choices, and then definitely modeling during story time and during play. So these adaptations are helping us help him participate successfully, generalize skills, and increase his confidence when talking amongst his peers and other adults. So the comparison or other alternative interventions we considered pull-out therapy, but ultimately it was not used due to research showing that skills learned outside of natural context or his preschool often generalize less effectively. So push-in therapy allows Jackson to practice language in a familiar and authentic place, which is his preschool classroom. It also helps allow for increased opportunities with other peer interactions, helps him follow directions, and use his AAC when accordingly. So this combination of is the most effective approach for him. So the recommendations or next steps moving forward for Jackson are to continue the push-in therapy embedded into the classroom routines to maintain child-led play and dialogic reading in the classroom, continue parent coaching to support language use at home while using that neuroaffirming practice, and to track progress through observation of AAC use, peer interactions, and following classroom directions. For future clients as well, these strategies provide a framework for integrating evidence-based practice with family-centered and neuroaffirming approaches. So in summary, Jackson's case demonstrates how push-in therapy, child-led play, dialogic reading, and parent coaching can work together to support language growth, peer interactions, and generalization of skills. By integrating external research, internal observation, and clinical judgment, we applied evidence-based practice in a real-world context, which is at the heart of our work as SLPs. Thank you. Do you have any questions for me? And last but not least, here are my references.
Sam, that was really good.
I'm really happy that was over.
Good job.
Yeah, I thought it was really good too.
Thanks. Just something about just like listening to myself, I just like cringed. So, it's definitely a rough draft. I also need to get more information from his IEP. I actually don't even have a copy of his IEP. I just like was jotting stuff down that my supervisor was telling me. So I'm gonna do that after I'm on fall break right now, but I'm gonna do that after we come back. But thank you, guys. Questions? Sorry, I just
No,
hate.
that was good.
I'm just cringing at my
It's
voice.
not as bad as you think it is, I promise. It's good.
Yeah.
Okay, I mean, mine is not any better. Mine is equally as rough draft, and I have a lot of information I think missing after I read an email from Denise. So, we'll see. But, okay, I don't know if I can share my screen.
Well, did you guys fill out the
Oh, yeah.
form?
Sorry.
Yeah, I need a couple minutes.
I'm just really excited to hear myself talk. All right. I'm ready if you guys are.
I'm ready to.
Cue. Okay. I don't know. Can you guys see that okay? Okay.
Yep.
I don't want to like kill your ears. I don't really know. Okay.
Hi everyone, my
Can
name
you
is
hear
Ellen
it?
Peoples, and today I'll be presenting a clinical case study. This case study highlights the importance of evidence-based strategies in supporting students with complex communication needs, particularly those who use augmentative and alternative communication, or AAC. So what we'll be covering today is I'll go over the situation, so who my client is, and then I'll provide some background information and the assessment findings. And then I'll share my PICO question that guided this case and discuss relevant interventions, including aided language stimulation and structured vocabulary access. And then finally, I'll summarize outcomes, recommendations, and clinical impressions. Before we begin, I want to go over some key terms. AAC stands for Augmentative and Alternative Communication, which refers to tools and strategies that support communication beyond speech. ALS in this context means aided language stimulation, also known as modeling, and it's when you use the AAC while you speak. Perseveration refers to repeating certain words, topics, or actions, often at the expense of other functional communication. Generative language means the ability to put words together to create new, meaningful messages. Pragmatic vocabulary refers to socially useful words like greetings, requests, or comments. And then finally, SPICE is a program for students with autism and related disorders who require highly individualized support. Okay, so the situation. My client is a 15-year, 10-month-old female in a self-contained SPICE 1 special education program. She has a diagnosis of autism and Phelan-McDermott syndrome, which is a rare genetic disorder that affects brain development and causes a range of neurodevelopmental disabilities. PMS is typically caused by a deletion or mutation in the SHANK3 gene on chromosome 22. This gene plays a crucial role in the development and function of synapses, the connections between neurons in the brain. And SHANK3 encodes a scaffolding protein that plays a crucial role in the structure of function of synapses. Okay. And then she presents with severe language and social communication delays, is minimally verbal, and communicates primarily through her AAC. However, she has difficulty accessing the device functionally and requires one-on-one paraprofessional support throughout the school day. She receives speech therapy focused on pragmatic, receptive, and expressive language, and occupational therapy for sensory and fine motor needs. Under her IEP, she qualifies under autism, and she's seen for 120 minutes per month, most of those being in group. So we'll push into the SPICE 1 classroom and work on her social communication focus. And then another day, once a week, we push into that same classroom, but do one-on-one direct therapy for 15 minutes with her. Okay, so the background. Looking at her developmental history, she met milestones typically until about 13 or 14 months. After that, she showed significant delays in language, communication, and adaptive skills, and she has been in special education since preschool. Social and behavioral, she perseverates on preferred topics like music, TV, and Disney. This changes as she finds another show or movie that she enjoys watching, or likes to listen to the soundtrack. And like I said, she communicates primarily using her AAC device, and some inconsistent modeling and misunderstanding of the device's purpose is kind of where we're at right now with the plateau in use of the AAC. So recent evaluations support her ASD diagnosis and document delays across multiple areas. For example, her autism spectrum ratings scales and DSM-5 criteria both fell in the very elevated range. Cognitive and adaptive functioning were in the delayed range with significant sensory processing difficulties, and language testing showed she is nonverbal on standardized measures, though receptive language is improving, and she requires modification instruction across all of her academics. Okay, so my PICO question is, in adolescents with autism who use AAC, does restricted access to perseverative vocabulary combined with structured modeling compared to unrestricted access result in greater functional use of academic or pragmatic vocabulary? So in other words, can limiting overused words and pairing that with intentional modeling help increase her ability to use language functionally in both academic and social contexts. So for the population, we have adolescents with autism who use AAC. Our intervention would be restricted access to perseverative vocabulary with structured modeling. The comparison is unrestricted access with inconsistent or absent AAC modeling by staff, which is currently what's happening. And then outcome would be greater functional use of academic and pragmatic vocabulary. So for the aided language stimulation, this is one of our evidence-based approach, and with the strategy, communication partners speak while simultaneously modeling on the AAC device. This provides consistent input showing the student how vocabulary can be used in real interactions. The goal isn't mastery of each phrase before moving on, but rather building natural exposure and opportunities to practice. This is particularly useful for students like our client who rely on her AAC. She uses restricted vocabulary and needs support in academic and pragmatic communication. Research emphasizes that it works best with all communication partners, so that would be teachers, paraprofessionals, and family, and they would have to participate consistently. Our second evidence-based practice is structured access to vocabulary, and this is just another intervention, and research shows that limiting perseveration items during instructional tasks while still allowing access during leisure or breaks can increase functional communication and reduce reliance on repetitive vocabulary. Importantly, the goal isn't to remove her interest altogether. Instead, we scaffold access so that new academic and social vocabulary has a chance to emerge while still honoring her motivation and personal preferences. Okay, so for my evidence, starting with external research consistently shows that aided language stimulation and modeling increase vocabulary diversity and spontaneous AAC use. Training communication partners is essential and effective across developmental levels. Internally, we see that this student is highly motivated by her interests, but perseverates without modeling. Her family and staff are concerned about limited functional use of AAC, but we've seen early success when modeling is provided. The challenge remains inconsistent pair use of the device and limited access to editing functions, which restrict vocabulary growth, and the inability to edit her AAC comes from a parental restriction. They won't give up the password for the AAC, so we're kind of at a crossroads. So we're going to supplement with the classroom AAC. So for the assessment, what's working and what's not working. So what's working is that we know she's motivated by interest in her routines. She shows engagement when adults model AAC use, and she uses her AAC to communicate what she wants, even though it's off topic. So she knows how to use it and understands when she wants or needs something, that's how she gets it. It's just not always accurate or appropriate for the situation. And then what's not working is the staff. So the paras inconsistently model AAC and have been seen removing the device from the student. Limited access to editing prevents tailoring vocabulary, which we don't have access to. And then paras may not fully understand AAC as a legitimate communication tool. So there's a little bit of a breakdown between it being a legitimate device for her to speak with and just a distraction class and something that she's using to make off-topic comments and noise. So why it matters is without aided language stimulation and structured modeling, the student defaults to perseverative vocabulary. So it reduces generalization of academic and pragmatic language. Research emphasizes partner consistency and modeling as key predictors of successful AAC outcomes. So once we have everyone on board, so the lead teacher, the paras, family, us when we go in for speech, as we keep using it all the same way and every single time, she will have a greater outcome with her AAC use. And then the current situation is just insufficient modeling, which is limiting her functional gains. Structured access to vocabulary creates opportunities for the student to expand language use beyond restricted interests. And combining modeling with controlled access allows communication partners to scaffold new vocabulary vocabulary use while still honoring the student's interests during appropriate times. So we're looking at taking her personal AAC away when we're in there for speech and during academic time and replacing it with the classroom AAC, but replacing the classroom AAC with her personal AAC during downtime so she can still have access to that vocabulary she wants to be using. And then recommendations based on both internal and external evidence, I recommend the following. So first, consistent staff training and aided language stimulation so that all partners can model use of AAC naturally throughout the day. Second would be structured vocabulary access, so limiting perseverative words during instruction, but allowing them during leisure. Third, collaboration with the family to address concerns about misuse of the device while promoting shared responsibility for editing and supporting functional use. And finally, staff education is key so that parents and teachers view AAC as a legitimate communication tool rather than a distraction. Research shows that consistency across environments is what leads to meaningful gains. And that concludes my presentation. Thank you for your attention, and I'd be happy to take any questions. Thank you.
Love listening to myself talk for 11 minutes. Okay. Do you guys have any questions?
I don't think so. I feel like you were really thorough. You did a really good job.
Thank you. I think I need to take some of those words off the screen. Okay, let me stop this thing.